Welcome everyone, good afternoon. I'm Emma Hoban, Manager of the Australian Centre for Value-Based Healthcare at the Australian Healthcare and Hospitals Association. Welcome to today's webinar, Making the Most of Technology in Healthcare, delivered in partnership with the Productivity Commission. I'm joining you on the lands of the Ngunnawal people and pay my respects to elders past, present and emerging. I would also like to acknowledge and pay respects to the traditional owners of the many different lands on which we meet today and recognise the continuing connection to land, water and culture. We've partnered with the Productivity Commission today to discuss their latest report, Leveraging Digital Technology in Healthcare, which finds making better use of emerging technologies could ease pressure on the healthcare system and save over $5 billion a year. A technology-enabled and data-informed approach is important for decision-making at all levels of the system, whether this is to support shared decision-making at the level of the consultation, for quality improvement in a service, for resource allocation, or to drive health system improvements across the entire system. We know that governments and organisations are investing significantly, but are these investments achieving value? And how are we learning from the experiences of implementation? Today we are joined by Productivity Commissioner Catherine de Fontenay to provide an overview of the findings of the Productivity Commission's research. Following this, we will be having a panel discussion in which Catherine will be joined by Simon Hill, Co-Chair of the AI Council at the Northern Sydney LHD, former Chief Information Officer of the Northern Sydney and Central Coast LHDs, and the now General Manager of the Hornsby Hospital, and Kylie Wilcock, Chief Executive of AHHA. So over to you, Catherine.
Thanks so much, Emma. Thank you all for joining today. I'm really excited to talk about our report. I'll just, there we go. I'll just quickly share my screen. Thank you all for your patience. There we go. Let me know if that's not working. Very excited to talk about our report, but in true government fashion, I'll start by telling you about another report that we wrote. So at the same time, we released a report on productivity in healthcare and found that although we're all very alive to the challenges of our healthcare system, actually productivity is growing amazingly well in our healthcare system. We found productivity growth of about 3% per year, which is well above the productivity we see in more commercial sectors of the economy. We also found that we outperform peer countries. We're third in a group of about 28 comparable countries. So that's really exciting and very good news about our healthcare system. And a lot of that is due to improvements in healthcare outcomes, specifically improvements in mortality rates from different treatments. And that's very exciting, but unfortunately, it doesn't address the many challenges that we have on the cost side. So as we know, we're struggling with growing costs as our population ages and as healthcare gets more expensive, increasing wait times, which are regularly in the news, and challenges to ensure equal access. So in that background, we took a look at digital technologies because we feel that they really have the potential, kind of for the first time in a long time, we have some technologies on the horizon that really have the potential to make a big difference to that cost and access side of the equation. And so it's worth taking some time to think about how they can help us. We took a look at 4 main areas. We looked at electronic medical records, telehealth, remote care, which is remote patient monitoring and digital therapeutics, and artificial intelligence. And again, they have a broad range of impacts, but probably one of the biggest is there's real potential to lower the costs of healthcare and reduce the pressure, particularly pressure on our hospital system. And that means more affordable and better healthcare. They also have the potential to improve the quality of healthcare in certain dimensions and to reduce the cost and increase convenience for patients. So a lot of very exciting potential on the horizon. We had a go at quantifying those potential benefits in a few of the dimensions, and they're pretty substantial. So from the point of view of consumers, we estimated that just looking at levels of telehealth that we're currently undertaking, we're saving about 900 million a year in travel cost and waiting cost in waiting rooms at GPs and hospitals. We found that in terms of good electronic medical records have the potential to save many millions in duplicate testing and imaging, and allow us to better manage our hospital resources, efficiently discharge patients. That could potentially save us up to about 5 billion a year. And the really huge benefits that are on the horizon are in artificial intelligence. So the OECD estimates that up to about 30% of the tasks that our health workforce undertakes could be done by artificial intelligence and other digital technologies. So that would be a saving of about 11 hours each week for every health worker. That's time that we can use to deliver healthcare to our rapidly aging population. So these are really exciting numbers in terms of the potential for these technologies. But as we all know, it's not clear that they're being used to their full potential for the moment. Clearly, AI is not, but even more established technologies are not reaching their full potential. So we had a look at that in this report. So turning first to the issue of the most vexed issue, electronic medical records. So there we really see that we're not living up to our full potential. A lot of hospitals are making investments in EMRs and are folding them into their own workflow quite well. The part where we're not really achieving synergies is in terms of sharing information between providers. And that is critical. So for example, hospital discharges, if they're shared with GPs in a quick and effective way, that reduces the risk of readmission by 79%, for example. Medical records need to be shared to reduce medication errors. But as we've all experienced, health information in Australia remains fragmented, it's in silos, and those silos don't speak to each other very well. Now, My Health Record was intended to be the solution to that problem, but unfortunately, it has yet to meet our expectations of a kind of final repository of most of our health information. So My Health Record suffers from incomplete information because individual providers make decisions about what to upload and when. It suffers from patchy coverage, and even when the information is there, it's awkward to use. It's been described as a shoebox of PDFs, so not ideal in terms of usability. And as a consequence, we're in what economists call a coordination problem. We have people not uploading to My Health Record because they're not seeing the benefit of it. And we have providers not looking in My Health Record for data because they're not sure they'll find what they need. And so we see low rates of viewing of records. And we see that use is particularly low among specialists and certain types of providers. Moreover, we see that a number of state and territory health systems are developing their own health system. They're often, several states are developing an electronic medical record for the public hospital system. And often they're setting that up so that different hospitals can communicate with each other, which makes a lot of sense. But some of those systems are starting to think about how they communicate with other parts of the system, and essentially are kind of duplicating the role of My Health Record. So those public systems are interfacing with GPs and community health, and we're starting to see duplication of these same functions. We also haven't had those fights about privacy regarding these new systems. And so we have this crowded space and we potentially have a lot of duplication of costs. So it's looking challenging, shall we say. So we still think that My Health Record has a really important place to play, an important role to play. And we think that it's important for us to focus very much on the basic information that needs sharing. So information on discharge summary uploads for public hospitals and for private hospitals. We need to ensure that all of those are in our My Health Record so they can always be accessed by our GP. We need medication information, including for non-PBS items, to be available in My Health Record. But really, if you think of the key information that you need when a patient moves from one system to another, it is what medication am I on? What happened when I left hospital? What are my current diagnoses? It's not a huge range of information. And so My Health Record is well positioned to play that role for all of us. That basic information could be automatically uploaded by software if we had the right incentives for software providers. So we need some coordination and we need to sort of keep our focus on some simpler elements of the system. We also took a look at telehealth. So this is a more positive picture than electronic medical records. So it has been a huge transformation that we've all been through since COVID. And the exciting thing is that telehealth is now a large and fully accepted part of our health system. So 1 in 5 GP consultations is via telehealth. 1 in 10 specialist consults is via telehealth. Alongside that, we have a direct-to-consumer telehealth system, telehealth sector that has emerged. So we have companies that are now providing fully online medical GP visits for consumers. These are generally not MBS covered, and this sector has grown very fast. And essentially, it's the consumer analog of what they are benefiting from in other sectors. It's the Uber Eats, it's the convenience at your fingertip. And consumers have shown that they're happy to pay for this new service. Meanwhile, hospitals are innovating and providing more services via telehealth, both to reduce pressure on the emergency room and to discharge people sooner, but also to provide support to regional healthcare services. And then we have supported consultations from regional and remote areas, particularly in ACCHOs, Aboriginal Community-Controlled Health Organizations, where Aboriginal health workers might sit with a patient and support them during a consultation with a city specialist. So these are extremely exciting developments in terms of improving access to healthcare. And we kind of have two big trends happening at the same time. On the one hand, convenience has increased for all of us. And we talked about those those big savings in terms of time and travel. But also access has improved for groups with less mobility who find it hard to get away from home, regional and remote patients. And so we've got some exciting trends going on there. So we think that policy settings here need to kind of carefully monitor and adapt to this evolving market. We have these new providers, these direct-to-consumer providers, who have very new ways of doing business. And we think that there's potentially some gaps there in terms of standards and accreditation for those new providers. A lot of our standards and accreditation assumes that you are receiving MBS funding for your activity. They don't fall under the normal definitions of GP services. And so we need to make sure that they're covered by our standards and accreditation. We also need to work out whether we're happy to have bundled services in this online. So some services that are being offered seem relatively low value, such as diet services or hair loss services. Do we want PBS funded services to be part of these online services? So it's a fascinating and rapidly moving area. Meanwhile, we have got rules that are in place partly to limit the cost for the government of this new direct-to-consumer segment of the market. We have the 12-month rule. So you can receive an MBS funding for your consultation if you have seen your doctor face-to-face in the last 12 months. So that rules out these fully online services. But it also potentially rules out access for some disadvantaged groups. So if I'm a remote patient and the nearest clinic is a long way away and I don't see them very often, I potentially don't meet the 12-month rule. If my local clinic is completely full for the next 6 weeks, I will be trying to see someone else and I don't meet the 12-month rule. So we want to look at who are these high needs groups who perhaps need relaxation of the 12-month rule so that they have good access to telehealth. It's perfectly reasonable that people in the city who are wanting additional convenience should pay for that convenience, but we want to make sure we're maintaining access and we're increasing access for these groups who can really benefit from telehealth. Another thing we heard in our consultation is that regional and remote providers are very worried about some of the potential implications of telehealth. They're worried that as more telehealth options arise, governments may put less effort into finding healthcare workers for those regional and remote areas. And again, that's very expensive and a lot of work to find healthcare workers, and we are in a healthcare shortage in those areas. They're worried that those shortages will get worse if governments invest in that less as telehealth options come up. So that's an area where we need to watch this space carefully and make sure we see how this is impacting remote areas. Continuing with the theme of remote care. So here we're talking not so much about remote areas, but care that is happening in the convenience of your home. So telehealth is one dimension of that, but two new and fascinating dimensions of remote care are remote patient monitoring. These are devices that track a patient's biomarkers. So this is probably the most exciting one, is devices that allow you to monitor a diabetes patient's insulin levels and make adjustments to those insulin levels. That is a game changer in the in the diabetes space and very exciting. It helps clinicians detect escalations in patient conditions, particularly if you're sending someone home with monitoring devices who's just been discharged from hospital. You can tell if their condition is worsening. And that's going to keep people from being readmitted unnecessarily to hospital. Then we have digital therapeutics. So these are apps, essentially, that help, for instance, with cognitive behavioral therapy. They've been shown to be very effective for certain types of psychological treatment. There's apps that help with rehabilitation from a cardiac event or a stroke, a number of different areas where apps have been shown to be effective. And again, they scale up very well, they free up clinician time, they have a lot of potential to help out in our health system. So here, this is sort of an emerging area. We found that 19% of GPs had introduced some form of monitoring, of checking on their patients, while 26% plan to introduce some in the next 2 years. And this can be very high tech, or it can be very low tech. I spoke to one doctor in remote South Australia who had patients who were 10 hours away with gestational diabetes. She was just having them phone in their insulin results and making adjustments to phone in their blood sugar results and making adjustments to their treatment. In terms of digital therapeutics, it's a little bit harder to tell what's going on. There are tens of thousands of apps. Only about 31 are TGA approved, but 74% of GPs in 2018, so even before COVID, recommended some form of app to their patients. Apps for sleep, there are apps for exercise. There's a broad range of options here. And then when there has been MBS funding for a specific area of monitoring or a specific type of app, the uptake has been more widespread. So again, the funding settings make a big difference here to how quickly this is going to catch on. So we think that the benefits of remote care could be better captured. We want to help consumers find quality products, especially in this app space. How can we let them know what is a good product and what is bad product? There's very little information out there when you start searching for apps. And we think that targeted funding arrangements could ensure that we get high value care. Remote care doesn't always fit in our broader funding models. There isn't always funding for undertaking monitoring of a patient. There isn't always funding for prescribing an app relative to, say, a mental health plan. And we think that high-value interventions with good clinical evidence could be funded, but also in ways that reward patient adherence. So lots to be done in that evolving space. Last thing we want to talk about is artificial intelligence. So again, there's huge potential there to make a difference. So we mentioned that up to 30% of tasks could be automated. So that includes non-clinical applications such as transcribing my notes, consumer engagement, helping people to check in, helping people to receive information they need prior to a treatment. There's using AI in diagnostic imaging and screening. I think we're all pretty excited about the potential for AI to detect the cancer where it might be missed by another person. And clinical decision support. So software that assists us providing that background information about what has been prescribed for people with similar conditions. So that's very exciting. At the same time, we can make better use of our resources by analyzing the data currently in our system and making better predictions and better resource adjustments. So discharging patients efficiently when they're as early as they're ready to be discharged. Identifying which patients in hospital are likely to have their condition worsen. Identifying which patients that we discharge need following up. South Australia has found that that really reduces the incidence of rehospitalization. So a number of areas where we can improve our predictions and improve our processes with AI. Again, the debate is very live all around us. AI does bring many risks, risks around data quality, privacy, and security of our health data. We're worried about decisions being taken by a black box process. So there are risks there, and we need lots of information and lots of checks and balances. Interestingly, Australia has very low trust and confidence in AI, particularly AI in health. Only 27 to 43% of Australians support the use of AI in health. So we have lots to do to restore confidence in this sector. And some of the reason is we have uncertainty about how effective our regulatory frameworks are in protecting us, in supporting us in this space. So what do we think should be done? Well, in some places, we actually need a little bit more regulation just to reassure us and to provide that confidence. The TGA has an approval regime exemption for clinical decision support software. If the AI is making the decision, then you need TGA approval. But if the AI is simply recommending a decision, you need notification of the TGA, but not approval. So we think that probably needs some tightening up as we transfer gradually more responsibility to these AI systems. We also want more formal follow-up of any AI system that evolves over time. And we think that we need privacy safeguards, we need lots of clear consent processes that are going to encourage people to share their data and know what is happening with their data. So that's pretty much it. I'll stop there, but in short, there's lots that is very exciting in this space, and we think that there's huge potential.
Thanks so much, Catherine. So now we're just going to bring in our other panelists, Simon and Kylie. But first, I'll just let you know that we do have Q&A function at the bottom of the screen. So if you do want to ask any questions, I've seen we've got a few coming through already. Please feel free to put them in and we'll get to them as we progress through the discussion. So Simon, I'd now like to start with you. Can you tell us a little bit about yourself, your background, and some of your work that you're involved in around embedding digital technology in healthcare and the use of AI?
And good afternoon, colleagues. I come from Darug and Gurungai country here at Hornsby Troonga Hospital. It's my pleasure to come and talk to the group today. I've been in public health for about 25 years and in a variety of roles, started in clinical informatics and redevelopment projects and have been a CIO and more recently a general manager of a busy and growing hospital. I think the use of technology in health, I see people saying they can barely hear me. I'll hold this microphone up to my mouth. Is really evolving. I think there's opportunities, lots of opportunities within health. We're only paper-based, 10, 15 years ago. So there has been this real acceleration in digitisation within the healthcare, but we really are only scratching the surface. It's really interesting to hear some of the comments and of the report that Catherine talked us through around where those opportunities may be. I think there certainly are pockets of excellence in that space. I reflect on some of the things that we're doing at the moment around voice recognition, substantial investment in clinical documentation and records, but still a long way to go. So I think lots of opportunity there for us, and I look forward to what the future may hold in that space for us.
Simon, Kylie, can you tell us a little bit about AHH's interest in this area?
Yeah, thanks so much, Emma, and thanks, Catherine, for your presentation on the report. We really appreciated the opportunity to contribute and also to connect you to health services as part of your exploration. So at AHH, we're really interested in that collective action that's needed, the action that will drive that improvement in health systems that no one part of the system can do in isolation. And I think technology is definitely one of those spaces. We're really interested in understanding what are the efficiencies that can be gained through a national approach, while also recognising the very unique environments across our country in which healthcare is provided. So how do we adopt digital technologies in a way that really recognises those circumstances? And I think you raised rural and remote in that context as well, and that's an area that we're working a lot at, because we do understand that at a community level that importance of technology to enable access to healthcare, but also recognising, as you mentioned, there are a number of providers coming in who don't form part of that system. So, thinking about what's that continuity of care, and we know that informational aspect of continuity is one part, the management is another, but the relationships that happen on the ground is another part that we have to be really cognizant of. And technologies can certainly support that, but it's a whole of system approach. So that's where we sit in the system in terms of trying to connect that local context in the adoption with some of the national policy that's being developed to support this. And alongside that is really understanding, how do we do this to drive value? And so recognising that there are so many different parts of the system that support that, from health technology assessment processes to our pricing bodies to our safety and quality commission. And you touched on all of those as you ran through your report about, the accreditation systems and things that sit with that as well. And then I suppose the third part of our interest, which is really where this webinar comes in as well, is around how do we create that learning health system around the adoption. We know that research to practice has been proposed to take, I think 15 years. It's improved since the 17 years, since I think, one of the older reference points that we used to use. But how do we do that better? How do we use, and we've been looking at how do we use a value-based healthcare framework to really do that sort of forensic analysis of, understanding the outcomes. And I think a question came around, is around how do we have that transparency in the outcomes that we're actually achieving for the costs that are invested, but also reflecting the context. So Emma, that's where we're coming from at AHHA, and I'll be listening intently to to people's questions and the feedback that we get today.
Thanks, Kylie. So we've got a lot of questions coming through the chat, so we might start there. So Catherine, you spoke about the incentives. Are you seeing any new approaches that might emerge to enable the system to evolve, whether it's uptake of new service models, i.e. reimbursement, or digital information flows, P4P or HIE market?
We are seeing some innovation and certainly, so for example, in remote monitoring and digital therapeutics, which are probably these categories where our normal funding models kind of don't fully incorporate it. I think the system, I think Department of Health and other actors are looking and learning. So we had the privilege of visiting the Royal Prince Alfred Virtual Hospital, which is quite a remarkable innovation. And there, both sort of state and federal are taking a look at what are the savings that we're seeing, what are the places where we're getting better care, where people are happier with the care because they can have care in their home. And so we're seeing that kind of watch this space as people observe and sort of work out what are the right funding models for this new type of care. With remote monitoring, though, there are some lost opportunities if we're not kind of paying attention to what is delivering high value care. So again, I mentioned diabetes monitoring as one of those real game changers. That is available for patients who have type 1 diabetes, receive support through the PBS system, I believe, but type 2 diabetes patients, even ones who have quite difficult circumstances and find it very hard to manage their own diabetes, even those types of patients cannot access these remote monitoring technologies. So we do want to continue to build that clinical evidence base of where these technologies make a huge difference to the quality of healthcare.
Thanks, Catherine. Simon, you're sitting at the point of implementation, being the general manager of a hospital. Are you seeing any new approaches that might emerge to enable the system to evolve?
Yeah, absolutely. I think the greatest potential for change is New South Wales Health is embarking on a journey around a single digital patient record. And I really think that this does provide significant opportunity to build through some of the silos, Catherine, I think you talked about. When I talk to clinicians today, one of the key frustrations they have is so much information that goes into the system, but we're still really unlinked. I think the example within New South Wales Health is we have 10 different instances of an electronic medical record that don't necessarily talk to each other. And the Signal digital patient record really is going to open that up for us. But I think the other thing it's going to do is create a common platform for us to not just enable our clinicians to unlock data sets that now they might need to go into multiple different information systems to access, but to build on top of. So I think it opens opportunities around AI, around interoperability, and things like that. So that's a big piece for us. The other thing that I'll just reflect on is we talked again before is how we're linking with partners, with community care providers, primary care providers, even health and public and private opportunities. There's some instances in Northern Sydney, LHD, where I work, where we do have health information exchanges open between private health providers and public health providers. And these, again, are innovative ways of sharing information that I think from a federal point of view, the opportunity to look at, Catherine, you mentioned privacy law and things like that. We're still a bit out of step with enabling that. And at the end of the day, it's just about us enabling our clinicians at the bedside, getting access to the information. We've still got a long way to go, but the single digital patient record really goes a long way to helping us open that up a little bit more.
Thanks, Simon. With digital technology and AI representing such a broad range of technologies, how important that we move away from the tendency to lump them all together in discussions and become more specific about which technology and AI will result in productivity gains. Kylie, did you have any thoughts on this?
I see Catherine nodding, so I'd love to hear her thoughts on that. But I do see that. And I think, with AI, there are some elements of, the use of it that can sit within individual clinical groups. So, looking at, say, radiology, but there's a lot of administrative workload that spans across our system, which have, they have very different risks and very different safety and very different funding implementation considerations. So I think it is really important to be thinking about AI quite broadly but being quite specific when we're talking about how we implement AI, that there really are, very different implications for the different types of technologies that are being introduced.
Catherine.
Yeah, I fully agree. I think because we're now at the pointy end, we need to talk about each of these technologies separately and figure out what we need in the policy space. On AI, I fully agree with Kylie's comments. So some types of AI are using data that is not actually sensitive. What time did you check into the clinic, and have you done your this particular check before the surgery? Other types of data are highly sensitive and going to need really different treatment. Some data can be put into a data set without risking the patient. So if we have a number of chest x-rays, they can be in a data set without that violating my patient privacy, for example. So we have a number of directions we need to move in, and they do look different for each technology.
Thanks, Catherine. Did you have any thoughts?
Yeah, I'd say again, we've only just recently started an AI council within CDLHD. The appetite from our clinicians to be involved in AI was huge. I was actually quite blown away with how many people are interested. I think the other side of it is that there isn't a huge literacy around AI and digital literacy. I think that's something that we, as a workforce within health, need to invest in. The language of digital, the language of AI, it can still be quite confusing, even scary to people what it might mean. And I think that we're still quite foundational in that. But absolutely, opportunity and interest is there. I'm always amazed with our extremely brilliant, smart clinicians and the ideas that they have around providing the very best experience for patients, and often technology is part of that. But I think building the technology and the skill set around digital, you still got a fair way to go within health. If you think about, the nurse on the ground delivering care, busy day, hundreds of people coming through the ED, our ability to ensure that we effectively manage that change and support our staff in basic digital literacy, we've still got a little way to go there, but absolute opportunity for us.
Thanks, Simon. That leads into a question around workforce. So we've had a few come through the chat around the need for training and how do we embed these models into business as usual without burdening a burnout workforce. So I suppose more generally, what impact do you see the growing use of technology having on the healthcare workforce? I'm not sure. Simon, did you want to start with that one?
Yeah, absolutely. I think in health, we're good at investing in the system or the tool, but we need to do better in managing the change and investing in the change. I think as we become more digital, the requirement around building our workforce around soft skills, around digital skills, I think is really important. I think we need to invest in change significantly. We do that quite well, but we could do better. I think the other opportunity for us is to be really honest and open about what we expect around the benefits. And I think that's a bit of an opportunity for us as well, is that you've got the patient benefit and outcome, which sometimes can be hard to measure in a dollar. But we know through digitisation, if I give you an example, digitisation of our medication management systems, we see great benefit around reducing wastage, improving outcomes. But in terms of when we talk about the need for accessing systems, my clinicians keep telling me that they're spending more time in front of the computer than they are in front of their patients. And ultimately, we still need to get to that balance where we're using these systems, we're using our technology to get these great outcomes, but it can't be at the expense of time and face time with patients. So I think there's still work to be done in that space. And I think managing the change is a key part of that and supporting that change.
Catherine, did you have any thoughts?
Yeah, fully agree with that, and it is a big investment to sort of come up with a system that is actually usable by health workers. The benefits that we measured, for instance, for EMRs, for electronic medical records, was from a hospital that already had an electronic medical record, but had improved their system and developed something in consultation with their clinicians that really worked for the staff and really allowed them to not bear such a huge impost. The other thing I'd say is that we're suffering from, we have this burnout, and we have a lot of people leaving the health profession. The ability to work from home is a non-trivial way to keep people in health who perhaps need to make a lifestyle change, need to make a change for personal reasons, but perhaps would still like to be involved. We heard of doctors that had been in remote areas, needed to move back to the city for personal reasons, but were still able to provide a lot of telehealth support to their old clinic, for example. So I think that telehealth does offer possibilities not just for patients, but for practitioners.
Thanks, Catherine. So I've got another question here from the audience. I know that there was very little specifically dedicated to digital health in the federal budget. Does the Productivity Commission expect the government to provide a formal response to your report? Catherine?
No, this is self-initiated research, so they're not obligated to provide a formal response. As we've mentioned, there are some cost savings as well as upfront investments that have to be made in this space. So there are, it's not clear that this is an area where we're going to need huge additional outlay, but it obviously depends on the specific technology.
Thanks, Catherine. There's a few questions coming in through the chat about the role of integration and the appetite of the states to kind of engage in a more coordinated response, which kind of links to one of the questions that I had for you. What role does the forthcoming National Health Reform Agreement have to play in more effectively supporting the integration of digital technologies and AI in the health system? Kylie, I'm not sure if you wanted to take first stab at this one.
Thanks, Emma. Look, I think it's got a critical role to play. So let's hope that it does play out when we, I think we're imagining July, we might hear something about where that's heading. Yeah, I mean, it's critical. Technology can't be implemented in isolation of the states and territories and the Commonwealth, simply because patients don't experience healthcare that way. These are artificial divisions, really, in how we, arrange our healthcare system. And technology needs to really support the care pathway that a patient experiences.
Simon, I wonder if you had any thoughts on being at that state level, whether the appetite of the various states to come together and develop a bit more integrated approach.
I think, as Kylie said, I think interoperability is crucial to this. And I think it's going to take a partnership approach. We've all got skin in the game. Public health providers, private vendors, legislators. I think it's really important because I think it is one of the key barriers for us at the moment. Until we can get to the point where we can start sharing information more seamlessly, and the opportunity it creates to build on top of that. We've all got vested interests. We've all got responsibilities, and there's an overarching legislation framework as well. But I think it is critical for us to be able to unlock the true potential of this place. Absolutely.
Catherine, did anything come through when you were writing the report or researching the report?
Well, so as we mentioned, we do have these concerns about sort of some duplication of costs that seems to be happening in that electronic medical records space. So Simon's absolutely right that interoperability is hugely valuable, and that, for example, the states that are developing an electronic medical record across their hospitals are getting, have some large potential benefits from that. But as a complete outsider, I guess I'd question whether it makes sense for all of the states to independently develop their own system that is bespoke to their state. That does seem like a bit of duplication. And so states that have not yet chosen a system and rolled out a system, they have lots to learn from, say, New South Wales and Queensland, and potentially we can reduce some of the duplication in costs that we're seeing.
Thanks, Catherine. We've had a few questions come through about the role of stakeholder and consumer engagement in the process of implementing technologies. So would the speakers like to comment on the importance of stakeholder engagement, how to identify key stakeholders, and how is the best way to engage them? In front of mine are the clinicians, the patients, and the decision makers who are holding the purse strings. Catherine, did you want to start?
Sure. We mainly heard about this in our consultations with regional and remote. So we heard very often that, say, when a new technology was rolled out to Aboriginal community-controlled health organizations, there was lots of funding for the technology. So the new retinal eye scan equipment would come in. There was less funding for training workers to use that technology. So Simon mentioned that helping workers to have comfort with the technology is critical. There's turnover in those health organizations, so there wasn't ongoing funding for keeping that capability with the technology. And then there wasn't necessarily a funding arrangement that allowed for a specialist in the city to be doing the analysis of that retinal eye scan. So when we roll out these technologies, we do need to bring we need a funding model and all of these stakeholders involved as we think about what a sensible rollout model could look like.
Simon, as someone that's on the ground, what are your thoughts on this? How do we engage stakeholders?
Stakeholder engagement, music to my ears, it is fundamental to any success. And I think we just need to recognise that there are so many different stakeholders. We've got our clinicians, we've got our consumers, we've got our vendors, we've got our technical people, we've got our doctors. And I often say nurses, allied health. I often say within health, one of the things that I've learned is we've got so many different groups that all have their own language. They all have their own requirements. And it's so important that in terms of any system change that we are engaging, and we need to take the engagement to them. We need to take it to the front line. We need to take it to our patients. We need to get their feedback, because it's so important in the overall scheme of things. I think one of the things I will say is I'm really excited that with our single digital patient record, 65% of the decisions that are going to be made into building the system will be driven from a user engagement process. And I think there's 70 or 80 different groups looking at all these different parts. And to know that 65% of the decisions that are going to go into building the system are from the users on the ground is really pleasing for us. So I think that's the thing. We need to have a user-centric design, get the input of so many people, and really use their feedback to drive decisions around building the system. I think that's a really exciting number for us, and expect to get a good outcome as a result.
Thanks, Simon. Kylie?
Yeah, thanks. And I agree with everything that's been said. And I suppose what I took from one of the statements in the report, that it cautioned that the ease with which these technologies can be rolled out risks a costly expansion of low-value services. And I think that's one of the critical reasons why we need to ensure that we do engage broadly with stakeholders, and that includes our consumers and our communities, to understand what it is that there is this often, I guess, an innate desire to have what's newest and latest, but actually understand what's that actually providing them in terms of the outcomes that they will receive, and what the implications of that are, will be critical to ensuring that we don't expand low value services and further risk, I guess, the sustainability of our health system.
Thanks, Kylie.
Sorry, Emma, just one point. Kylie made a really good point there. The digital literacy of our community is quite high, and their expectation for digital interaction with healthcare services is there too. And if you look at healthcare as an industry compared to finance or real estate, we're a long way behind that. So patients expect to interact with the health service, and there's so much more opportunity to do all of this. So I think that's going to be a real benefit for us. The clinician advantage, but that the patient experience as well, their expectation of digital is something that we think that the single digital patient record and other things are really going to help drive improvements in.
Thanks, Simon. I completely agree with that. I once heard it phrased as consumers are being trained by other industries, and then for digital literacy, and then they get to healthcare and it's just not there. So building on that, I'm wondering if you had any thoughts about how we can kind of leverage these other industries that are so far ahead of healthcare and collaborate and learn from them.
That's
Catherine?
a great question. I think some of it is just that observation and kind of just an observation of how it's being done in other industries. Why is it that if you go into a hospital, you give your personal details 4 or 5 times in a row before your surgery? To some extent, we'll get that feedback from consumers that it's not the same consumer experience as they're getting elsewhere. I guess that's what we're seeing in telehealth, is people are looking for that convenience and ease of access that they're experiencing in other parts of the system. Now, if that's ease of access for services that are valuable for them to get, that's great. If that's ease of access for a service that's less valuable, we maybe don't necessarily want to encourage that.
Thanks, Catherine. Simon, sorry, Kylie, I can see you're ready to answer. So, Kylie.
Yeah, it reminds me of a story that we heard from some of our colleagues in the system around the way our sporting groups have that connection with people for life, that cradle to grave. Cricket, they'll sign you up in the beginning of your life for a cricket, but they're thinking about what team you're going to be playing for as well as then who you're going to be going for when you become an adult, and they're really engaging you. And I think that's something that when we think about relational continuity of care, it is about the relationship with health and healthcare, that we think about that for life. And I think that there's another opportunity for us to learn from those kind of systems around how we engage people in their health over time too.
Simon, did you have any thoughts?
Yeah, absolutely. And Catherine and Kylie both talked about it. It's that partnership approach is what we need. And often, how do you find out? You ask. And I think the big opportunity in health is how we're partnering with our universities, how we're partnering with our vendors and our private partners in building these systems and asking the question, what works for you? And I think that's something certainly we're looking at within Northern Sydney. We've got a really great opportunity in terms of our physical infrastructure. We've been able to build simulation centres where we actually invite colleagues from other industries to come in and experience a day in the life of what it's like to be an emergency clinician. And conversely, we should be using that opportunity for partnership around building our digital experience. What are your customers telling you? How can we work differently in health to build that digital experience for healthcare?
This other research we did on productivity in healthcare found that the healthcare system is incredibly good at finding out what the latest treatment is overseas and folding that into best practice. So we really are getting top-notch care. When that cancer treatment improves overseas, we're folding that into our practices here. We're using the medicines, we're using the treatments. But when it comes to digital technologies, we don't have that same mindset of we should be best in show, you know, and so it's kind of an interesting contrast.
Thanks, Catherine. We might just move on to the issue of cybersecurity, and I know this is a very touching one for a lot of people, but cybersecurity is a significant challenge for healthcare organisations. In the US, remediating breaches in healthcare has been estimated to cost almost 3 times that of other industries. With our healthcare system comprising of so many organisations of different sizes, are we ready from a cybersecurity perspective to take advantage of the productivity gain? Catherine.
That's a great question. Look, I think we need to ask some hard questions about what data needs to be shared and how much needs, and sort of how often. So again, one of the reasons we do think My Health Record continues to play a key role in sort of record sharing across the system is that a system can upload those basic things that are needed to be shared into My Health Record, and then the cybersecurity risk rests with the Australian government. Within a hospital, if a hospital system wants to share with all other hospitals, there are some big investments and big risks that are involved. There's also big gains, as Simon was pointing out. Hospitals at the level of their own electronic medical record can make decisions about how much is shared outside of hospital walls. So one hospital we spoke to, specialists that are on call can view all of the patient's records and make decisions, you know, sort of speak with great quality of information about what should be done by the people that are on site. That's terrific in terms of an information, but it obviously raises more cybersecurity risks. So there are going to be some trade-offs.
Kylie?
Yeah, thanks, Emma. I certainly don't have any comments around the solution for this, but I do think it's something we need to be critically aware of, is the costs of cybersecurity to services. And if services are already questioning, you know, their own viability and financial sustainability, those exactly what Catherine just referenced is those questions about, you know, it's not just an open up all information for everything, but thinking about how do we ensure that health services have the funding that they need to do this properly, but that we're ensuring the right data is shared at the right time, to the right people for decision making, not just broad sweeping scale decisions for this very reason.
Thanks, Kylie. We've probably got time for 1 or 2 more questions. So another one from our audience. How much is the Digital Health Blueprint and Action Plan 2023-33 influencing or guiding the panel's area of focus work? Simon, is this something that's guiding your work?
Yeah, look, I think it's there. I think it's something that we're considering in terms of all of our investment decisions. Is it at the forefront of our decisions? No, but it certainly is something that we factor in. Look, it's important. It's important to have framework. It's important to have guidelines. It's important for us to understand what the vision is and, you know, where we're heading. We also are looking to build that capability, you know, within New South Wales Health and informing how that would mean for us. So, look, like I'd say, it is a factor and it's an important tool to help us for sure.
Catherine, did you have any thoughts? No, okay, no problem. So that probably brings us to our final question of the day. If we are to harness and make the most of technology in healthcare, what do you think are the critical next steps needed? For each of you, if you had one wish and could only ask for one thing, what would it be? Catherine.
Ooh, what would be my wish for the next step?
Next step.
Probably a revision of funding rules, looking at sort of remote monitoring and digital therapeutics.
Thanks, Catherine. Simon?
the number one thing, I think I may have mentioned it before, that the feedback I get from clinicians is, Simon, we want tools that enables me to spend more time with the patient. So there's no easy answer to that. And I think we've talked a bit around some of the foundational things, some of the legislative things that will help to drive that. But for me, if I had one thing, it would be, how can I enable an environment that my clinicians are the human side of healthcare, no matter what digital technology, AI means for us, it needs to complement us. How can we support our clinicians?
Kylie.
Thanks, Emma. Look, it's a nice broad one. Commitment from every stakeholder within the health system to be cognizant of the outcomes they're looking to achieve, the costs of implementing those, and the context in which they're being implemented.
Thank you very much. So that brings us to the end of our webinar today, Making the Most of Technology in Healthcare. Thank you so much to all of our panelists for joining us today. That was a great discussion and really interesting starting point, I think. At the AHHA and the Australian Centre for Value-Based Healthcare, we host regular webinars on topics related to value-based healthcare. Our next webinar will take place on Wednesday, the 19th of June at 10 a.m, where we will hear from the 2023 Value-Based Healthcare Innovation Award-winning project, the Breast Cancer Bundle of Care model. So this model brings together stakeholders from across the health system, create an innovative, person-centered, value-driven model of care. So it should be a great conversation. Find out more about our events and activities, see the AHHA website, and you can also subscribe to receive our monthly newsletter or join the Australian Centre for Value-Based Healthcare LinkedIn page to be part of the conversation. Thank you again for everyone for joining us today, and we look forward to seeing you again at one of our upcoming webinars soon. Thank you.
Thank you. Thanks so much to the AHHA. This is great.